welcome. Uh, so Dr. Lights, we appreciate your time very much. Obviously, Jacob,
Yeah.
Christian State, here we are.
Glad to be here. Heard a lot of great things about you, man.
Well, I hope I live up to them.
I'm sure you already have. Seeing the notes you brought in, seeing the preparation, seeing your dog get on doggy daycare, today, just brought it again to me.
Yeah. But no, ideally what we're just going to talk about is men's health. That's our big topic with us. Obviously, fertility world. We'll get into, my experience with you specifically. But who is Dr. Likes, a little history, background, gosh into this.
Yeah, so I'm Creighton Likes. I'm born and raised South Carolinian. I did med school in Charleston, did OB residency here in Greenville, actually, and then did my fellowship at Duke and fertility. And then I've been back here for almost 15 years. So I've lived in Greenville for almost 20 years. I've always loved the intricacies of fertility, and it's kind of like putting pieces of a puzzle together. And so that's what drew me to it. I also have a background in genetics. I have a master's before med school. And so that kind of parlayed my interest in fertility and other things. So I am double board certified in OBGYN and fertility. As I practice fertility, I'm actually opening a new fertility practice with CCRM, which is the Colorado Center for Reproductive Medicine. I'm here in Greenville, only one in South Carolina, and they have other satellites all across the country and even in Toronto. So it's a big system, high up in the scales of fertility world. So it's gonna be great.
That's exciting.
Yeah, exciting, absolutely.
Now, when you started I want to be a doctor, high school doctor, what was that transition? Were you always interested in fertility, or did you just know?
Yeah, that's a good question. So
Found to it?
I'm the only doctor in my family, and my father was a hospital CEO. So I've been around hospitals all my life. And I just was drawn to medicine, quite honestly. I think it was because of taking care of people. When I went through medical school, I tried to keep my options open. That's what everybody tells you. But I was always drawn to the OBGYN and fertility aspect. I had worked with some fertility doctors. I worked obviously with some OBGYNs. So that's just where it felt most comfortable in terms of my experiences and my knowledge, and then where I could take that. So that it was at an early age, yes, that I knew I wanted to be a physician. And then through med school, and then my experiences with some mentors is when I honed in on where I wanted to go.
It's awesome. Good stuff.
Way better than me. You were born and raised around the environment.
Yeah, good or bad.
That's impressive that you still stoked a passion for it and an interest for it, because myself, I was raised in the machine tool world. My dad's a machinist, a fabricator.
Yep.
I developed a resentment and a loathing for that entire field because I was around it so much. I think that I just went opposite.
So I completely get that. And that brings up a memory. I would walk around the hospitals and I would see these physicians walking around kind of moping, right? They're young, smiling. And I said to myself, I remember this. I said, if I ever become a physician, I'm not going to look like that, because he does not enjoy, or she does not enjoy, this job. And so that kind of worked in my favor.
Right. So
I try to keep that.
Yeah, use it kind of as a hedge to, not become that way. I like that.
So I try every day.
I love it.
It's hard, sometimes.
It's never easy.
In anything you do.
Nothing's easy, but yeah. So it's what makes it worth it. So
nice. So kind of how me and you met.
Yeah.
So I'm always, as everybody will know, I'm very transparent, very honest. So young 23, 24-year-old John, wanting to be jacked, a big guy, started taking anabolics. In the fitness realm, just thought it'd be cool, party in college. Let me take this testosterone and all this stuff. I had no idea what I was doing. Downstream, I was probably, 28, 29-ish when me and my wife, she wanted to have kids. I was always, if it happens, cool. If it doesn't, no big deal. And I was always the dogma of, my friends have kids, right, doing the same stuff I'm doing.
Yep.
We're fine. If anything, I was kind of more of an asshole saying, honey's something you got to get tested.
Yeah,
I'm fine.
Right.
To expedite that, a few years, 3 or 4 years, same thing, nothing's happening. And then she finally convinced me to go get tested. I've shared that experience before, where for men at least, I can't speak for women, that's always an awkward experience. But going through that, we had a previous doctor, which I won't state his name, but let's just say the experience was,
You already have
yeah.
on the previous one.
Did I? Well, it'd be, I could find out. But it was, which I feel like sometimes doctors, and I'll even say this in some kind of context, trainers are somewhat relatable, where it's just the clientele, your patient and you don't mesh well.
Sure.
And it was just not a positive meeting. Sitting next to my wife, doctor comes in and pretty much, I would take it as a joking fashion, saying like, I'm not betting on you guys getting pregnant. That was one of the first statements. My wife is not a very emotional woman. And it was the quiet tears rolling down the face here, and I had zero sperm, nothing. So I felt immensely, we were just devastated. Sure. We left that appointment you hear stories of that, but I could not tell you the lowest of lows.
Sure. Absolutely.
Out the door. I'm going to look her name up in a minute. Broderick?
Oh, Denise.
Denise Broad, yes. I'm glad I remembered. She worked with my wife, referred you. We go to it. We go into that meeting thinking, just a low. Like, this just isn't happening. And I can't explain to you the experience that we had. You didn't fluff. You didn't tell us, you're getting pregnant, here's the answer. But your energy, your aura, how you communicated facts, we left there the exact opposite. Not that we thought, oh, we're getting a baby for sure. But it was just like, okay, this sucks. But the positivity, energy, like, hey, let's attack this. We just felt good. So the environment you facilitated in that, I can't thank you enough. I know you get thousands of these a day.
No.
But like, you play a puzzle and you pieced that puzzle to us having Zane. Whether you may think it was a small thing, and that's something we can never say thank you enough. We still talk about you obviously daily. But just to let you know that just experience that is probably every day to you, it is unmeasurable from mine as a man to see my wife happy, obviously to have a son that I wish I would have got tested earlier. I've been a little more proactive, hence why I have this podcast I'm gonna dive into, of things I could have done to known I was actually the issue of having no sperm because of things I chose with testosterone and TRT clinics and HRT clinics and things like that. So diving into that,
Well, I want to thank you for saying that, by the way.
of course, I mean, yeah, if you absolutely, I know it's just,
appreciate it.
it's just your job, it's just,
That means a lot.
it is. And it's not just me. We talked before this. Your tentacles, as I've said, have reached a lot of people, sir. I don't put my name behind a lot of people, but you're one that I've always, thank you. So that's the guy, so, now diving into that realm, which I'll let you jump into. So obviously HRT, TRT, testosterone, all these hot topic words are popping up. And from your view, from your clinical side, has there been a correlation with this word or clinics of this popping up and these infertility rates? And the pros, cons, like kind of what is your scope of it?
Sure, that's a great question. And let me answer that by backing up in terms of the rates. Because I don't know if a lot of people know the rates, and you actually kind of alluded to it yourself just when you were talking. So when I see couples, I have to tell them about 30% of the time, 30 to 40% of the time, it's a male factor. Another 30% of the time, it's a combined factor, meaning both male and female. So it's not like, oh, I just have to focus on the female, right? So I have to take that, and I probably told you that too. I have to take that into account. What are the numbers? The other thing, and this is going to what you just said, is studies have shown, you probably know this, over the last 40 years or so, male fertility has plummeted. In fact, some studies in reputable journals have shown that the quantity of sperm value has halved in those 4 years, and the quality and motility has also decreased. So there is a pervasive male infertility issue or male factor issue that's coming on. This is worldwide, not just in the U.S.
Right.
So that maybe goes to your question as to why. I can't tell you that it's these clinics that are popping up.
Yeah.
There are probably undoubtedly other factors that are contributing to those numbers I just quoted. Lifestyle changes, possibly using anabolic steroids. But chronic disease, obesity, smoking. These things are getting a bit more common that we see, and that's going to undoubtedly contribute to the male factor that we're seeing.
But it's not just a one thing. It's
correct.
It's not one. We can't like put our finger on one.
Personally,
And I would never pretend to, right?
Correct.
We hear people all the time on these podcasts, as we were kind of like talking about before this, they'll almost like pinpoint one thing, like, oh, it's the quality of air, or it's what's in the water.
Oh, absolutely. They'll hear that a lot, and that's how they sell things too, right?
Right. And so it's like, I'm sure that every one of those things might have a component to the big picture, but it's not one thing.
Correct. I mean, it's the multifactorial, right?
Yes.
That's what it comes down to. Right. But also to your point, I mean, I see patients a number of times that have been put on testosterone, either by physicians or they go out and get it themselves, and they're not maybe relating that, well, I'm also trying to have a child with my partner. But you see these ads on television of the downtrodden men. They have low energy. Well, maybe you have low T. Well, maybe you do, but don't go on testosterone if you're trying to get pregnant, right? Because that will plummet the numbers. And to your point, not everybody's going to be the same. Not everybody's going to have the same effect if they take testosterone. Meaning, I've seen some patients taking testosterone and they have zero sperm. Then I've seen some that have taken testosterone and they still have sperm in their ejaculate. So it's not a one-to-one, just like we said.
Yeah.
But we don't know that it can decrease it. To the point that they're trying to make an oral contraceptive pill with a testosterone progestin.
I think Japan produced a pretty cool study on that.
I'm not sure if it was Japan, but I know in the States that it has already crossed some hurdles in terms of regulation. So that in and of itself tells you that some form of testosterone is a male contraceptive. Right? And not to mention the other side effects.
I would say I do remember reading a study that it wasn't in a medical journal, American Medical Journal, but it was in one of the Asian countries where they administered a group of men. It was a high dose, like 600 milligrams of testosterone and anthe for a 12-week period, and then they basically tested their sperm count and quality afterwards, and it was like 98% of them were infertile. But I mean, that's a high dose, so I bet it's a bear.
And I've seen that I practice.
Right.
And that's essentially what they're doing to themselves. And that's why they have azospermia or zero sperm. But in that regard, the good, and probably the oral contraceptive that may be coming out, if everything else is normal for the male, if they stop it, your sperm production should come back.
Right.
Now that takes time because the maturation of the sperm takes about 80 to 90 days. And so it's going to take time to see a repeat semen analysis show sperm, but usually it will come back in terms of production. So that's
good. Gave me hope. I mean, I'm going to get into some of my personal questions with you in a minute, but that's me and my wife are just in the beginning stages of having those conversations about I'm open with her about decisions I've made and mistakes I've made, hormonally speaking. But, my doctor actually said very similar to what you just said. He said, if you had it before, we can hopefully get it back.
Yep.
It's just going to take time.
Correct.
So that definitely gives hope to the guys out there who might feel like they had none,
Absolutely.
So, yeah.
And that's what I tell patients with the very same thing when they come in and we have these initial semen analyses. So that's the other thing I will say. 9 times out of 10, I'm going to tell a patient, well, let's just repeat this semen analysis in X amount of weeks to months and see what it shows. Now, I know that's hard because you're trying to conceive and you don't want to wait that X amount of weeks to months, but it is what needs to be done. Now, if it's completely zero sperm, then we may go down another road. We could talk about that later. But
yeah. And that was the kind of piece. I won't give you the exact protocol of what you had given me, but with me being at zero, I specifically remember the one answer I liked from you, or it was in the realm of it, was my goal is to get my wife pregnant.
right.
What is the quickest way to make this happen?
Yeah.
And I enjoyed the very direct, and it was completely come off of testosterone. We were going to start this protocol. You were very self-aware of like you were not going to feel great for a while, which I think my levels were alligator sign over 1,500 on blood work. Like 12 days, I dropped to sub mid threes.
Yeah.
The Clomid, you did not feel great.
Yeah.
But it was September-ish, and I remember in February she was pregnant. So I knew that was a pretty quick turnaround as to what occurred in my field. So again, the outcome was great. And I always like that transparency. Now, when you approach patients, do you all levers up because you think this is the goal, this is what we need to do? Are you like all poker chips in, or do you approach it like, let's do one little thing at a time, or does it kind of?
That's a great question. So I didn't mean to cut you off. No, I honestly try to read what the patient or the couple are telling me. And I'll be honest, 9 times out of 10 or more patients are coming to me because they've been trying X amount of months already and they want a baby yesterday, right? And I completely understand that. That goes to my point of saying, if you've been trying and you think you need an evaluation, go get one now. Don't wait. But also to your point, if they are in that state in terms of we've tried X amount of months, I'm going to say, okay, we're going to look at everything. And then based on what we find, we're going to put together a protocol that's going to be as aggressive as y'all want to be. That's what I always tell patients. I'll be as aggressive as you want to be. And I will lay out what those protocols look like. Usually it's kind of like a stepping stone in terms of protocols of aggressiveness. And based on the information I have from the evaluation, we can move forward this way. So usually it can be fairly aggressive, yeah. So,
and just for the majority of obviously people are watching this, they have no idea concept of numbers.
Yeah.
When I say I was at 0, for most males, and I was mid-30s at the time, what's an average, sperm? And if you wouldn't mind, touch on the actual volume and then like the quality. Quality versus quantity.
So when you do a semen, or we have patients do a semen analysis, we go by the WHO standards, okay, the World Health Organization standards, and we look at certain parameters of those semen analyses. The 4 main parameters are volume, concentration, motility, and morphology. So it's the volume, and they all have average normal numbers that you're trying to hit, right? The volume is going to fluctuate depending upon frequency of ejaculation and so forth, but we get a number for that, and it's usually 1.5 mils or so or more. But really the more important are the other parameters. The motility, how many are moving or swimming, right? And we have different subsets of motility for progression and so forth, but that needs to be 40%. The concentration, how many million sperm per milliliter? We want 15 to 20 million per milliliter.
So you want 15 to 20 million sperm. Of that, you want at least 40%.
Got it. And then the morphology is the shape. So they grade sperm under the microscope. They give them a grade of either normal or abnormal. That's it. And normal is a normal shaped sperm. Abnormal can be a misshapen head, 2 tails, whatever the case may be. And the morphology based on the WHO only needs to be 4%. 4% normal. So that means 96% of the sperm can be abnormal, but 4% or more is normal.
Wow.
Is a normal analysis. So those are the parameters we look at. And based on those parameters, I may say, okay, we need to repeat this because those numbers can definitely fluctuate from one to the next. Or based on the numbers.
Pretty drastically? Like, is that a pretty big sliding scale?
They can if you've been on testosterone, right? I mean, if the concentration is really low and you stop it and then you repeat it, your concentration may be already normal now.
That's true. Yeah, because I know I went from 0 to, I believe in December, it was 2 million. Yeah, it's around there.
So, and you're proving that point, right? But if it's a persistent thing in terms of the repeat semen analysis, then we may be more aggressive from the male side. And when I say that, you may remember from the female side, I have a lot of medicines I can give women if it's an ovulatory issue or surgery, if it's a uterus issue. I don't have a lot from the male side. It's either let's try this, or if it continually stays low, well, then we're moving on to IUI or IVF. Well, we can talk about that later if you want to. But it's different in terms of how aggressive the treatments are from which side you're looking at, male or female.
And that's just depending on the patient. So like with HCG and Clobit, you don't have to get exact amounts, obviously.
Yeah, that's good.
Let's say you've maxed.
Yeah, I mean,
we're not getting traction here.
Correct. So if I can look at that in 2 ways, you're right. So HCG injections are sometimes taken because they work like LH on the brain, right? And Clomid. Women take Clomid fairly frequently. It's been around for years. Works the same in men, but men just have to take it continuously. If those numbers aren't coming up after a repeat semen analysis, that's when I shift gears to say, this isn't working for you, and let's move to something more aggressive if you really want to have a success. Or if the numbers are still up, or excuse me, have gone up, and you're still not have success with conception, then I might say, okay, we're going to give it this amount of many months. Because what I don't want to do, and I tell patients this all the time, I don't want you to feel like you're spinning your wheels.
Yeah.
So if it's been 3-4 months and then nothing's happened, it's time to regroup and let's figure something else out. That goes back to the diagnosis in terms of when should I see a fertility specialist? So, and unfortunately or fortunately, I don't know, that's based on the female age. That's historically what it's been on, because women are born with all the eggs you're ever going to have, whereas men will typically produce sperm well into their late years of life. So it's based on the female age as what the books will tell you when to see a fertility specialist. But there is something called advanced paternal age, just like there's advanced maternal age. And so things can happen with age in men. It's just typically later in life. So that's why the numbers are based on the female age. But again, I will tell patients, male or female, if you have a thought that you want to have a child and you've been trying and it hasn't happened, go see a specialist. I always say, be your own advocate and don't hesitate if the thought comes to you. Because the worst case scenario is you just have a few tests and everything says, okay, I feel comfortable with that, or no, I want to move forward with that treatment.
And now you know.
And now you know.
Sadly. Yeah, sorry I had to step away briefly there for a moment. I did have one question, actually two, but the first one, speaking on the maternal and paternal age, we talked about briefly the how much we've seen male fertility decrease over the last 20-ish years or so.
Yep.
And sorry, that's fine. Had you seen a correlation between that, or maybe not even between it, but also the rise in PCOS type symptoms being a complication for females as well? Or is that maybe it's just from like conversations I have with women. So it seems to be more prevalent these days.
So part of that is probably the ability to diagnose.
Understood.
Yeah. It's just like, we were diagnosed with breast cancer earlier. It doesn't mean it may be prevalent, but I'm just saying more cases, right?
Understood. Yeah. We have a better
way of diagnosing it. The number one reason women have fertility issues and come to see me is from an ovulatory standpoint, whether it be PCOS or something. So it is fairly common in and of itself. I don't know if it's a correlation.
Right. And then the second question, this actually, I think a lot of our followers, probably both me and John, would really love to know the answer to this, because
I hope I have it then.
Right. And it might just be a good conversation point, but there's been a study that's thrown around talking about male football players and the sperm quality due to them being intense athletes, having their testicles in a cup, right? The temperature change. What is it about men who are either athletes or undergoing anabolics for a long amount of time and their propensity to have female offspring? Is there any relation there? Because there's more and more data coming out that I've been made aware of about, like, basically if you're on anabolics, your sperm, like, you have a higher likelihood of having it. Yeah. And I just subjectively, every dude except this guy that every guy that I know that has run anabolics or currently in the competing network that has kids seems to spit out daughters.
And thankfully Zane looks like me, or I'm up wife.
Well, no, and I haven't heard that. I don't know if there's any validity to it. I've been hearing more and more about the temperature exposure or certain things like that change the motility or like this.
Yeah, but that's not necessarily going to change the DNA. Right?
Well, what's the answer? Yeah, what's very high level for most listeners that determines male female? See the chromosome, but is there a temperature difference, or
It's flip of a coin, as far as we know right now.
really? So it's just
Yeah.
There's really no rhyme or reason.
Not that I can pinpoint right
Even a sauna or a freezer. Or
So, I mean,
that.
not usually those factors are going to affect global fertility. It's not going to affect gender.
Okay, gotcha.
Yeah.
I mean, we do tell patients, like you alluded to, the football players, boxer briefs, not the heat.
Yeah.
Laptops on your on your pelvis, those sorts of things. Bicyclists, saunas, those things. We know that can affect the numbers of the semen analysis.
Okay. Yeah.
But I wouldn't say that it's going to affect which gender.
Understood.
child you have.
Understood. It just maybe it's just an interesting correlation. I do, and I might just be psychotic. It's just like every time I have the conversation with a guy who's run a lot of PEDs, and they have kids, they're having girls. And I'm just like,
I mean, it's very common in the bodybuilding.
yeah, so we from there.
Bodybuilders,
Like,
like female, yeah.
yeah. So I'm just curious. I didn't
I'll have to go look it up. I'll be honest. That's the first I've heard.
try to find the source because it was actually a legitimate one. Like unlike the data I was discussing about supplements, you know how it's conducted, but it was actually a decent analysis. I just can't remember where I saw it.
So, oh, you told me something. That's good. Wait,
I might be. That's the thing. I could be wrong. Like I could be misreading the data.
So if we could pivot a little with our amazing drawing here.
Yeah.
which we take no credit for.
Yes, 100%.
Okay.
But just a very 101 of,
Yeah. Feedback.
we'll call it a mini John, from the pituitary, the regular cycle how it should be.
Okay.
And if, let's say, a young male, whoever, decided to,
Take steroids.
yes, certain thoughts he should have are very basic, like, this is what actually can happen from a,
All right. So basic action. Pituitary's in the brain, right? It's gonna work. Spits out LH, luteinizing hormone. I mean, it does chock full of other hormones.
Yeah.
This is the one we're going to talk about. So that feedback to the testicles to make sperm
Okay.
and increase testosterone.
Right.
T here comes from this into the bloodstream and gets feedback. The testosterone gets feedback to the pituitary.
Okay.
So if the testosterone is appropriate in a normal cycling pituitary, what's called the HPG axis, the hypopituitary gonadal axis, if it's normal, this will say, okay, brain says I have testosterone. I don't need to secrete as much LH. If it decreases, then LH should increase because then it wants to produce more.
Right.
What happens in taking exogenous testosterone, you're basically bypassing this, sorry to put the X there, and giving it T, the body. The brain doesn't care where the testosterone is coming from. It knows that it's there. That's all that it cares about. So what does it do? If it has testosterone, it shuts down LH because that's the feedback. So you're constantly taking this testosterone, you're constantly lowering that pituitary release of LH. Well, what happens then? There's no signal to the testicles anymore. There's no signal to the testicles, sperm.
They don't need it or has a reason to make more.
Right, because in the normal cycle, sperm production and testosterone increase go hand in hand. But if you're giving the testosterone somewhere else, the brain says, oh, I don't need it from here anymore. It doesn't know that, but that's essentially what's happened.
Right.
Does that make sense?
Yeah. Is this what we're looking at here? Is this the basically overview of the HPTA axis as it's referred to, or is that a different thing?
No, that's
I mean, that's kind of
the A may be adrenal. I don't know what you're talking about, but this is the hypothalamic pituitary gonadal or testicular axis. Yeah,
gotcha.
it's called the HPO in females, but ovarian axis. But yeah, I mean, there's obviously a lot more to it than that. You know, I have more hormones, but that's the 30,000 feet look in terms of why testosterone exogenously shuts down the brain from making LH and the sperm production goes down.
Understood.
two parts to piggyback off of this.
Yeah.
A younger male who has no testosterone issues, or not hypo or things like that, taking testosterone back out. There's not an exact time frame of when that loop resets. Continue back resets.
Everybody's going to be different.
Everybody's there.
It's got to be a variable. But like I said,
So going into that, though, as young listeners going to a whatever, maybe a TRT clinic and not even knowing if they're actually hypo or whatever that may be, there's a strong correlation between taking testosterone and fertility going down.
absolutely. I saw 2 patients in 3 days that had taken testosterone. Their sperm count was 0.
And it doesn't matter whether you're taking, or which I'm sure it does matter, but 50 milligrams, 500 milligrams.
Great question. I think one, like I said earlier, it may affect everybody differently in terms of the degree of which it will decrease the sperm production. But yeah, I'm sure there's probably some sort of correlation in terms of the dosage that they're taking and the amount of effect it will have on the LH. But the bottom line is if it does affect it and it is decreased, if everything else is normal, the good news is that 3-6 months down the road, sperm production should be back.
Yeah. And the reason I ask is just mainly in my realm with fitness and the dogma of, pro science, as we call it. There's a lot of, oh, well, I'll just take a little less, yeah, and it'll pick back up.
Yeah,
Or I don't need to come all the way off or do a TRT dose.
That logic is so flawed to me, even in the neuroscience world, because after as you explain how this works, really, in my head, I'm like, it doesn't matter how much is being administered. It's still being given. So it's preventing that feedback loop from continuing.
Yeah.
No matter what.
Correct.
But I hear that all the time too. Or I'll hear guys that still run their same dose and they're like, oh, I'm just going to go get some HCG and just start administering a random dose of HCG.
And they think it's
users.
So to be clear, HCG works on the same LH receptor. Everybody take it, and so they think they're going to
Upregulate it.
Yeah.
Now let me ask you this. So is there a situation where somebody medically still needs to be administering testosterone and you also want to be able to get this feedback loop going?
I mean, from a fertility realm, if it's sperm count is low and it's not because of them taking exogenous testosterone, there can be a place for Clomid, there can be a place for HCG.
Okay.
But not necessarily. I have had patients say, well, I want the testosterone because I feel better on it, but I'm also going to take the HCG, just like you said.
Understood. Yeah.
That's not a success.
Yeah.
Also, if their sperm count is low, again, not because of exogenous T, there could be other factors going on.
Understood.
And so that's when the evaluation comes in. That was part of my what I was going to say in terms of the workup was first real easy things, then a little bit more in depth. One, when you have your semen analysis, most likely the person taking you back is going to ask you, do you have any fevers or anything in the past 3 months? And they'll say 3 months because what was going on 3 months ago
Was what was producing the sperm in your sac today.
right now.
Oh, yeah.
So if you had the flu, COVID, whatever, fever, that can affect your outcome now. And so that's just a simple question to ask, and that's also why we sometimes really repeat, or not sometimes, oftentimes repeat them. Also, history-wise, so we always ask about taking testosterone, smoking, those sorts of things. Marijuana, that can definitely affect it as well because of the pituitary effect. But then you ask about family history. And one thing that I don't think a lot of people know about is we ask the men if they have a family history of cystic fibrosis in their family. Right? Cystic fibrosis is a lung condition, amongst other things. And Caucasians, we carry about 1 in 29 or so, somewhere in there. The reason that's important, there are hundreds of different mutations that cause cystic fibrosis. You have to have 2 mutations. So you can be a carrier
Without being
affected.
right.
But men who are a carrier of a CF gene mutation are at an increased rate of having what's called congenital absence of the vas deferens. Okay, so they have no tubes that allow the sperm to get to the ejaculate. So everything else, their hormones are normal.
Yeah.
But they just don't have the tubes to,
And they're still producing the sperm.
they're still producing it. They're just sitting there and getting reabsorbed. It's not in the ejaculate. So they can come out with azoospermia as well.
Okay.
Now, this is rare, but it's one of the more common genetic mutations in the Caucasian.
Well, yes.
You like it, quite honestly. So that's another question we ask about, because that's a whole nother conversation from a fertility aspect. So that's what I mean in terms of the evaluation. We're going to look at the picture, look at and ask these.
I love that. I love that. Well, I mean, that's just that puts a higher emphasis on seeing a professional such as yourself in the first place and not playing the guessing game.
Right.
And just trying to take shots in the dark on what Reddit forums you're reading on the internet.
Yeah.
You know, I mean, and that's, and we see that a lot in the gym and especially in this world, man. I mean, actually 2 of the guys that have come in since we started this cast are guys that I have tried to send to my doctor even because I trust him.
Yep.
They will not go and sit down with a doctor because they're scared. And they ask my advice and ask me to look at their blood work, and I'm not a medical professional.
Yeah.
I look at these panels all the time, but I'm not going to pretend to ever diagnose or treat. It's not my role.
Yeah.
So I think it's very important, guys, if you're watching this, anybody, on the nutrition store page or the content that we're putting out, make sure if this is something that you've done, you've administered testosterone to yourself, and you are at a point where you want to consider having kids, make sure you do get professional help and seek an expert. I can't, emphasize the importance of that enough.
Yeah.
So,
And to piggyback again, I was that guy. Oh, fine, honey, it's you.
Yeah.
Because I was afraid. I'm not afraid, but I didn't need that. I don't know if there's ego or
talk conversation.
It's
with yourself, man.
difficult. I mean, there's some machismo there, and I get it.
Yeah.
I would have, full transparency, we had trouble having our first child, and I didn't know if it was me.
Yeah.
But we were almost to that point of I was going to have to be tested as well. And it is something that you have to understand. That's why I put those numbers out there, those percentages, because we were talking earlier, this is fertility or infertility is not necessarily something that you go and talk about in large groups all the time, right? Yeah. You don't really want to expose that sometimes, and I get that. But once you do open that door, you'll see there's a lot of folks that go through. 1 in 6 couples have fertility issues. 1 in 6.
Yeah.
So it's not as talked about, but it is prevalent. And so if you can make those bridges, I think it helps you overcome some of those things that you may be not fearing, but thinking about that you don't want to do.
What are the actual rates? Healthy male, healthy female.
Great.
Just for them to get pregnant.
Right.
Normal.
Yeah. Check it. So there's a joke amongst the fertility realm is that we're not really good at procreating in general. Be honest. So let me pose this question to you. So in nature, how many percent-wise of every fertilized egg, how many of those go on to make a live-born baby? Do you know?
Probably less than 1%. If I had to guess, look, it's a very low.
It's not that low, but it's there. So 75% don't go on to make a live-born child.
Okay. Yeah.
This will also go back to female age because, again, as women age, because they're born with all the eggs they were going to have, egg quality decreases, miscarriage rate increases, chromosome abnormalities increase, leading to more miscarriage. So we base it on the female age. And so under 35 in a couple, female age under 35, everything's perfect. She's ovulating each month. His side of things normal. There's only about a 20 to 25% chance to get pregnant.
Really?
Wow. If everything's normal. When women approach the age of 40 and at 40, that rate drops to 5% or less.
Wow.
Each month. And then after 40, it's
And that's
max.
obviously having intercourse during their
Absolutely.
wow.
So that's another point I always make in terms of timing. So everything we do is based on, is predicated on appropriate timing. So to your question or point, timing of intercourse is important. If the female side of things knows the ovulation window, it's important to note that sperm can live in the female tract for up to 5 days. But if you haven't had intercourse before she ovulates and you wait till after she ovulates, you're not going to get pregnant because there's only about a 12 to 24 hour time frame that egg can survive after ovulation. So I always tell patients to start having intercourse every other day or every day, a couple of days prior to ovulation because of that.
Fact, I'm clipping this portion. Oh, yeah.
Because of the fact that sperm can live in the female tract, and then if you've had intercourse and then she ovulates, you should already have sperm.
Now, does that tie back to, and maybe I misheard you, when you ejaculate, does the sperm count go down or the quality?
You mean if it's
Like like honey, I'm going to save it all for this.
no, you don't need to do that.
Okay.
In fact, let's just
Submarine chamber effect, we should say. Like,
I mean, you're not going to deplete it
Okay.
in this small amount of time frame. I'm saying in the fertility window and the ovulation window. The normal menstrual cycle is 28 days. Not every female has a 28-day cycle. So let's just say day 14 is about ovulation. That's what the books will tell you. So I'll tell patients day 9 or 10 of your cycle, of the female cycle, start having intercourse. Remember, day 1 is when full flow. 9 days later, start having intercourse. Have intercourse every other day for 4 or 5 times, not 4 or 5 times a day. Yeah. Every other day, 4 or 5 times, that should catch that fertile window when she's ovulating.
Okay.
Does that make sense? Yeah. But it's before she ovulates.
That's actually really good to know because, like, and that's, you know, like me and my wife are not to that point yet. Like, we're in the discussion period of like learning her ovulation window, and that's actually great information for me to take home and just to be aware of is the duration of time that sperm can stay, thriving,
Viable. Yeah.
Yeah, because we're like, oh, okay, your ovulation is next week. Yeah, not knowing that, then we'd be waiting till it's the tail end, whatever. So that's really good to know. I appreciate that.
Absolutely.
Now, a hot topic word, and then we'll get to some Q&As here and have some fun. Okay, so vaccines. Yeah. Now, so we don't get political and all that stuff, but is there any correlation or all this crazy stuff you hear when vaccines, X amount going up and the correlation to infertility or things along those lines?
I just wanted to say really quick, and I don't know when we decided that science needed to overlap with politics, but unfortunately we've got it out of the way of the world. And so when we ever even bring up the word vaccine, it immediately in most people that word now, right? And it's unfortunate. Well, anyway, continue that. Yeah.
So, full transparency, I am a huge proponent of getting vaccinated. And to your question, and I'll make it brief, there are no long-term studies of vaccines causing fertility issues. The biggest thing you heard about, most likely, is the COVID vaccine when it came out and the causation or correlation of irregular menstrual cycles in women, and therefore could that affect fertility. Subsequent studies have shown that that was short-lived if it happened at all, and it's not a long-term fertility issue. They could have some variation in their cycles, but not a long-term necessary fertility issue. You flip that around, not getting vaccinated and getting some of the potential diseases because you don't get it, that can have fertility issues and factors. So it's important to know that. Now, the other thing I will, and this is the last thing I'll say, is because, like you just said, vaccines are a hot topic. And so we get asked a lot, if you're going through fertility treatments, like IVF, in vitro, and you're going to have an embryo transfer, or you're going to have an IUI, insemination, they'll ask, do I need to have because I'm due for my whatever, COVID shot or flu shot. Usually we'll say, if you have reactions, and people have reactions to vaccines, it's very normal. I got 103 temperature from the first COVID vaccine, but I just chalked that up to a good immune system. But in the fertility treatment, if you're going to have those reactions, we say maybe space it out so you don't have that inflammatory reaction around the time of your embryo transfer. So there can be some play in terms of when we talk about vaccines that correlate to a fertility treatment. But again, long term, it should not affect your fertility. And it's quite the opposite. If you get some of the diseases, they can affect your fertility.
Awesome. I haven't heard of anything related to the COVID vaccine on like a reproductive health.
The biggest thing that came out was some irregular cycles.
Yeah. I've heard a lot of testimonial statements about the cardiovascular potential side effects that are starting to present themselves to some populations. I'm not sure though.
I think it's been refuted as well.
Okay. Yeah. Like I'm very pro-vax in most situations, but I also understand the customers that I'm dealing with on a daily basis. I have to, be very neutral.
Absolutely.
But
I get it.
Yeah. So
I get it.
But
so yeah, lastly, before we get into these fun,
and then want to ask him really quick that I'll pull that.
Well,
Oh yeah, go for it.
Okay.
Oh, you should. Okay. No, so you mentioned Clomid.
Yep.
What's your thoughts on the ever so popular research chemical that is starting to make waves more so? It was available in compounding pharmacies as of last year. Now it doesn't seem to be as accessible in clomiphene citrate. And your thoughts on that compared to Clomid or clomiphene citrate?
In terms of
effectiveness, side effect profile, would you have a use case for one over the other in certain situations? You think?
I usually would stick with a traditional glove.
Understood. Okay. Yeah. It seems, they're both SERMs, right? Like they both have very similar mechanisms, just the structure's different.
Yeah.
Okay.
It's like, there's lots of different variations on SERM. Tamoxifen.
Yes, sir.
That's a breast cancer medication. That's a SERM.
Yeah.
I've used that to help women ovulate as well.
Okay.
Just like Clomid. You just take it for 5 days.
Understood.
Femara. Letrozole.
Yeah.
So all those are...
That stemmed from a conversation with my buddy who's a nurse practitioner who, he has more of a specific focus in the HRT wellness side of things. And so...
Yeah. So...
Yeah.
And I know who I'm speaking to right now, but I will say from the compounding pharmacies, the supplements and such, sometimes the percent or the actual volume of what the medicine is in those can vary.
Yeah.
Right.
Yeah. There's not much standard of...
Right.
Yeah.
That's actually a problem.
Yes, sir. Yeah.
So
and he was just talking to me about the mechanism of enclomiphene, and he actually said that it might not be a bad idea for me to consider as I continue lowering my dose, because Dr. Al wants me to basically, my TRT, we've taken it down from 175 milligrams. I'm down to 100 milligrams a week now. And we were talking about enclomiphene and its potential to help with any of the low T symptoms that occur, like the energy, the mood altering effects. And I didn't know if there was any implications on enclomiphene versus Clomid.
In that regard, I don't think it make too much of a difference. But again, from a fertility standpoint.
Yes, sir. Yeah. Go with the one that's then actually,
and the testosterone.
Yeah. Understood. Yeah. Gotcha. It's good enough. Anyway, yeah.
One more thing I wanted to mention before we get to Q&A, or we can do whatever. It's important. I'm big on fertility preservation. We hadn't talked about that, but we start thinking about what down the road could affect a person's ability to produce sperm. And the biggest thing that we talk about, cancer diagnoses, chemotherapeutic regimens that are going to treat those, and what's called gonadotoxicity affecting it. So if we have a patient, and I've seen teenagers, unfortunately, get these horrible diagnoses, and their oncologists will have the wherewithal to say, you need to go see Dr. Likes to talk about fertility preservation. So I only put that out there because I think it's important to think about, because how many 15, 16-year-olds are thinking, well, I've got this, I want to get through it, but I'm not thinking about children down at 25, 30 years old. So we can free sperm very, very easily. And it's a very tried and true thing that may save them a lot of heartache in the future. It's just something to a topic to broach with these patients. I think we've focused on what we've can reverse almost if it's exogenous testosterone. But what happens if it's not reversible later on? Can you do something to be proactive? So yeah, I just want to.
I had that conversation last night, actually. Yeah, sir. Yeah. A lot of younger men come in and talk to me. Obviously, I'm 29, so like I think I might be a little bit more relatable to the 21-year-old, and who I was the 21-year-old who decided to do all the steroids and harm myself. But I always use the statement, when you're 21 or even 18 through the 23, 24 area, you can't see past Friday night.
Correct.
And so for you to tell me at 21 that you don't want a family, you don't want to get married, I get it, bro.
Yeah.
I was there when I was 21. I didn't care about settling down. And then now, fast forward 8 years, I'm at a completely different phase of my life. My goals and priorities are different.
Absolutely.
And so, like, if I could go back in time and at least impart that knowledge on my younger self,
right.
to think ahead and preserve my potential a lot more effectively, I would. And it's always a hard conversation to have, because even at my age, not being that much older than these guys, they still, the youthful arrogance is like, oh, this guy, old timer, but they're, no, but you know what I'm saying? Like they do not see enough into their own future to be able to take that information seriously, and it's unfortunate.
Agree, but I commend you for saying stuff. But also, it's also that's not every oncologist or not every other kind of type of physician brings that up. So I just wanted to mention it. Yeah, I think it's a good.
That's great
way to be proactive and not have something happen to you in the future that you regret not doing early on, and it's very easy, let's face it, and not very costly.
Yeah.
So is there anything, before we do the rapid little questions, from the supplement world, and again, I may be off tilt on both ends here, but like with and I may say this wrong, the morphology or with a vitamin E or something with oxidizing with that cell, things that could help.
Yeah. So that's a good question.
In that environment?
Yeah. You may know better than I, but I don't know if there are any rigorous randomly controlled trial studies on to look at supplements.
The moment you throw an RCTS like that, they're not going to be there,
because they're not FDA regulated. Right? They do this GRAS, generally regarded as safe, and that's how supplements get to the market. It's $1 billion market, right? That being said, there can be some detriment to some supplements, right? And they can have effects on other organ function. So you have to take it with a grain of salt, but also do your research and talk to these kinds of folks. But also, we do have a cocktail of vitamins and supplements that we give our male patients, and it's vitamin E, vitamin C, L-carnitine, and coenzyme Q10, CoQ10.
Carnitine has some good data on it I don't know about the sperm cell count, but it does increase seminal volume or fluid volume. Idea that this data's solid on that. You want to blow some big loads?
Oh, damn.
I will not be telling about all right. He's not. I'm saying that's me. I'm rough around the edges, but no, I appreciate you saying that, because that randomized control trials, that needs to be something that's advocated for on this side of the fence.
It's gonna be hard.
It is. Yeah. It is, and I don't know if the current person who's sitting in the chair is going to help things much.
What's the other?
Yeah, we're not going to have that conversation. I'm sure we would agree, but I do know. And once again, it comes down to the problem with how the studies are conducted. Correct. In this industry. That's correct. It is a lot of it is subjective. It's survey data. And unfortunately, me being a graduate of an R2 school myself, that's the only type of literature I was able to conduct was survey data-based stuff. And so we're going to give this to you, John, for 12 weeks, right? And we're going to basically have a series of questions where we check at multiple points along the way to ask you symptoms or get your feedback. But the way those questions can be framed can steer the narrative of your answer. Correct. And that's where I struggle with a lot of supplements and fertility or anything. I do know that Tomcat Ali, Fedosia agrestis seems to have some interesting stuff for fertility, but that's even correlative. Same thing with fenugreek. And that's with, female breast production. It's hearsay. A lot of it's like up in the air. If you come to me and you're already seeing a professional like Dr. Likes, I'm going to say just listen to your one source of information. Yeah. Like, I don't ever want to come between the medical professional and their recommendations.
I can completely appreciate that. I'm not going to sit here and say, don't take any supplements. I'm really not.
No.
Like I said, we have supplements that we recommend. I can't, but here it is. I can't, like we talked about earlier, I can't put my finger on saying, this is why this isn't happening because you're not taking enough CoQ10. That's the reality, right? It's better. It's mainly, it's not
Foster the environment.
correct. It's not harmful, these vitamins in these certain ranges that you take. So it may help. The one thing I have a problem is, I'm on Instagram a lot. I post a lot of videos trying to be informative about fertility and other things, medicines. A lot of the feed in my feed I get are these influencers and people selling stuff. And that's, they almost guarantee a quick fix. They guarantee a cleanse or a flush or whatever they want to call it.
Sasa Likes, tell me how that works.
Yeah, right?
I mean, because last time
They don't know either.
God put 2 kidneys and a liver in our body for a reason.
But here's what I say to those folks.
I should run a supplement store.
They're out to make money and pad their pocketbooks. And two, don't you think if it was that easy that I could tell you to take this one thing that we would be doing it as well, right? I mean, if it's too good to be true, it's too good to be true. It's the bottom line.
We'd like to pause this from a word from our sponsors, Alpha Brain. Or AG1. Brought to you. No. Okay. Anyway. Yeah. Sorry. That's my role. I will crap on those companies and brands because I don't care and I'm not on their payroll. But it is funny, man. There's so much money to be made. There's so much pitched, and as long as you're ethical, like that. That's the thing. That's why I can really get behind the creatine that I make. It is one ingredient. It's monohydrate. I have it HPLC tested. Like it is. Yeah. It's up to par. But I'm also not saying anything about it. Like I'm not sitting here telling you it's going to do this. Correct. But yeah, be ethical, man. That's
Agree.
If I could slap my industry across the face with an ethical hammer, I would. But
So lastly, and again, I keep saying this before we dive into these. Sorry, this will get funny here quick. Oh boy, anybody interested in reaching out to you?
Okay.
Like, what the best way to find Dr. Likes?
I'll be honest. In this day and age, social media.
Yep.
Love to hear that. Instagram. I'm active on Instagram.
I love it too, by the way. I love it.
So I will say it's Creighton Likes MD, because if you just put Creighton Likes, that's my son. Because I'm the third, he's the fourth.
So you're gonna get some awkward.
Right. So it's just Creighton Likes MD, and I look at.
Where did that name come from? If you don't mind me asking, because I've never heard.
Yeah, I'm the third. So obviously my granddad was the first one. The rumor is, and I don't know because I never knew the original Creighton, was that my grandmother's doctor, OBGYN, ironically, last name was Creighton. Yeah, I don't know.
Cool name. I like it.
Thanks.
Reminds me like Kratos or something like that.
The God of War. So if somebody wanted to essentially schedule a consultation or an initial with you, would social media be how they go about doing that? Or
because I'm in that limbo in terms of opening a practice. I know I'm not. It's going to be a little bit. So, yes, a direct message, DM, or Instagram.
I'm going to get that conversation going with you today then,
Yeah.
just so we can plan ahead to shut it down. But yeah, well,
Perfect.